Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 306 of our pharmacotherapy series, which majors in chronic stable angina. The first question applies to patient EHR from part 305 of this pharmacotherapy series. EHR undergoes percutaneous coronary intervention plus stent placement and returns to your pharmacy to have a new prescription filled. The prescription calls for clopidogrel at a dose of 150 mg once a day for 1 week, then 75 mg a day thereafter with 11 monthly refills. You have not seen clopidogrel dosed in such manner and are wondering what the rationale for the higher dose is, and whether there is evidence to support its use. Clopidogrel, a phenylpyridine, inhibits platelet function as a non-competitive antagonist of the P2Y12 platelet adenosine diphosphate receptor. Clopidogrel is dosed at 75 mg daily, and this dose has been demonstrated to be effective and safe as monotherapy, or as a component of dual antiplatelet therapy with aspirin, in a wide variety of settings for patients with coronary artery disease. Despite proven efficacy, patients continue to experience clinical events while receiving clopidogrel. It is now understood that clopidogrel does not produce a consistent antiplatelet response in many patients. Although the term clopidogrel resistance was first used to describe patients who do not have the expected antiplatelet response to standard doses of clopidogrel, a better term to describe this phenomenon is clopidogrel nonresponsiveness. Alternatively, the phrase high on treatment platelet reactivity is also used commonly in the literature, especially when characterizing the clinical consequences of decreased antiplatelet response. The presence of high on treatment platelet reactivity in patients who have undergone percutaneous coronary intervention has been linked to a higher rate of stent thrombosis, myocardial infarction, repeat revascularization, and death. This link has been observed in both stable coronary artery disease patients undergoing elective percutaneous coronary intervention, and patients with acute coronary syndrome. Although non-responsiveness identifies an elevated risk for ischemic events, not all patients with identified clopidogrel non-responsiveness necessarily go on to have recurrent events. There is a lack of consistency of how clopidogrel non-responsiveness is defined. It may be defined as the presence of a recurrent ischemic event while on therapy. But, thrombosis is a complex interplay of many different factors, and recurrent clinical events do not necessarily imply a lack of antiplatelet effect. The identification of a lack of the expected biologic effect on platelet function is a more appropriate definition to work with. However, there are multiple tests available to assess the antiplatelet activity of clopidogrel and other antiplatelet agents, and it is unclear which assay correlates best with clinical outcome and would be preferred to assess clopidogrel nonresponsiveness. Because of the variability in available platelet function tests, as well as definitions of non-responsiveness, estimates for the incidence of clopidogrel non-responsiveness range anywhere from 5% to 44%. Potential reasons for clopidogrel non-responsiveness are multifactorial. One source of non-responsiveness is in the decreased biotransformation of clopidogrel from its prodrug form to its active metabolite. Biotransformation is a multi-step process through the cytochrome P450 system, but the most important enzyme is CYP2C19, which exhibits variable metabolic capacity. Patients with the STAR1 CYP2C19 alleles are considered extensive metabolizers and are capable of generating sufficient levels of clopidogrel's active metabolite. Patients with one or two copies of either the STAR2 or STAR3 alleles, considered loss of function alleles, are considered either intermediate or poor metabolizers, generate lower amounts of active metabolite, and generally produce a reduced antiplatelet effect as measured with available platelet function testing. Conversely, patients with one or two copies of the STAR17 allele, considered a gain of function allele, are considered ultrarapid metabolizers and demonstrate a heightened antiplatelet response with clopidogrel. With the unraveling of pharmacogenomic factors related to clopidogrel response, a great deal of attention has been given to the idea of identifying patients with copies of either the STAR2 or STAR3 allele and adjusting antiplatelet therapy accordingly. The FDA added language to the clopidogrel package insert specifying that poor metabolizers have a higher cardiovascular event rate, and that tests are available to identify who those patients are who carry these genes. Although the presence of either loss of function allele has been associated with an increased risk of clinical outcomes in some trials, this finding has not been uniformly observed. Additionally, there are no prospective trials evaluating a strategy of genetic testing with subsequent therapy changes. As such, genetic testing related to clopidogrel therapy is considered to be in the investigational stage. An alternative approach to address the issue of clopidogrel non-responsiveness is to assess platelet function in patients receiving clopidogrel. To date, trials conducted have indicated that increasing loading or maintenance doses of clopidogrel do have the potential to convert patients deemed non-responders to responders. However, not all patients can be converted, and no trial has demonstrated that such an approach leads to improved clinical outcomes. Additionally, data indicate no improvements in clinical outcomes from platelet function monitoring. Empirically, using higher doses of clopidogrel in all patients undergoing percutaneous coronary intervention is an additional approach that has been considered in addressing clopidogrel non-responsiveness. Although no trials have been conducted in the elective percutaneous coronary intervention setting, the current OASIS-7 trial randomly assigned more than 25,000 acute coronary syndrome patients to either standard dosing of clopidogrel, 300 mg load, then 75 mg daily, or a higher dosing regimen, 600 mg load, then 150 mg daily for 7 days, then 75 mg daily. Patients were also randomly assigned to either high dose, that is 300 to 325 mg daily, or low dose, that is 75 to 100 mg daily aspirin. Approximately 17,000 of the 25,000 patients underwent percutaneous coronary intervention. Results showed that in percutaneous coronary intervention patients, the higher dosing regimen of clopidogrel reduced the risk of myocardial infarction at the cost of a higher incidence of major bleeding. Although the results of the current OASIS-7 trial might be viewed in a positive light in relation to the prescription EHR is presenting with today in your pharmacy, an important caveat is that the current OASIS-7 trial was conducted in acute coronary syndrome patients, and it is unclear if the same benefits and risks can be expected in patients undergoing elective percutaneous coronary intervention for symptom management of chronic stable angina. The next question reads, while you are filling her new clopidogrel prescription, EHR mentions that she has been having some problems with heartburn lately and asks where she can find some over-the-counter omeprazole. Is omeprazole appropriate to use in a patient with clopidogrel therapy? Another source of variable clopidogrel response is through potential drug-drug interactions involving the CYP2C19 enzyme. One class of agents that has generated substantial controversy in this area are the proton pump inhibitors PPIs, given the likelihood of co-administration to prevent GI bleeding as a result of antiplatelet therapy. Several studies indicate there is a pharmacokinetic interaction between proton pump inhibitors, in particular omeprazole, with clopidogrel resulting in reduced levels of the active metabolite. Evidence that this interaction is clinically significant is variable. Several retrospective analyses suggest an increased risk for cardiovascular disease events in patients taking proton pump inhibitors with clopidogrel therapy. However, the available evidence from randomized controlled trials does not support an increased clinical risk with this combination. However, one study has identified that proton pump inhibitor use alone is associated with an elevated risk of cardiovascular disease events. Clinicians are faced with addressing this issue from a medical legal aspect as the FDA has incorporated language into the clopidogrel package insert warning against the concomitant administration of omeprazole and esomeprazole with clopidogrel. The recommendation applies to omeprazole and esomeprazole but not other proton pump inhibitors. There is some evidence to suggest that alternative proton pump inhibitors such as pantoprazole have a lower propensity to inhibit CYP2C19 and interact with clopidogrel. Until further information becomes available, clinicians should first validate the need for proton pump inhibitor therapy in clopidogrel patients. If acid-suppressive therapy is needed, the use of AH2 antagonist, excluding cimetidine which can inhibit CYP enzymes, or a proton pump inhibitor less likely to interact with clopidogrel would seem to be appropriate options to consider. The next question reads, ASP, a 35-year-old woman, is hospitalized for evaluation of severe chest pain, which occurs almost daily at about 5 a.m. ASP ranks the severity of pain as 7 to 8 on a scale of 1 to 10. It is associated with diaphoresis and is not relieved by change in position. ASP has no cardiovascular risk factors, and her hobbies include triathlon competition and rock climbing, neither of which has caused chest pain. She follows a strict vegetarian diet and takes no medications. Admission ECG reveals sinus bradycardia at 56 beats per minute. Serum electrolytes, chemistry panel, and cardiac enzymes are all within normal limits. On day 1 of hospitalization, ASP is awakened at 6 a.m. abruptly by severe chest pain. Her vital signs at this time include the following: heart rate of 55 beats per minute, supine BP of 110 systolic 64 diastolic, and respiratory rate 12 breaths per minute. An ECG shows sinus bradycardia with marked ST segment elevation. The pain is relieved within 60 seconds by 1 nitroglycerin 0.4 mg sublingual tablet. During the day, she completes an exercise tolerance test without complication or evidence of coronary artery disease. On the second day, ASP undergoes cardiac catheterization, and no coronary atherosclerosis is visualized. ASP is diagnosed as having Prinzmetal variant angina. Discharge medications include oral amlodipine 10 mg every day at 11 p.m. and nitroglycerin lingual spray 0.4 mg as needed for chest pain. Is ASP's presentation typical for Prinzmetal variant angina? ASP presents with a classic picture of variant, that is Prinzmetal, angina, with transient total occlusion of a large epicardial coronary artery as a result of severe segmental spasm. Clinical manifestations include chest pain occurring at rest, often in the morning hours. As with ASP, patients with Prinzmetal variant angina generally are younger than patients with chronic stable angina and do not carry a high-risk profile. Other vasospastic disorders, such as migraine attacks or Raynaud's phenomenon, may be present. Smoking and alcohol ingestion can be important contributing factors. The hallmark of variant angina is ST segment elevation on the ECG, which denotes rapid and complete occlusion of the coronary artery. Many patients also have asymptomatic episodes of ST segment elevation. Transient arrhythmias and conduction disturbances may be observed during pain, depending on the severity of the myocardial ischemia. As documented by angiography, ASP has vasospasm of the large right coronary artery. This transient, reversible narrowing is probably caused by increased coronary vascular resistance. It can occur in the absence of atherosclerosis, as illustrated by ASP, and also in the presence of coronary artery disease. One possible explanation for vasospasm occurring more commonly at night or during the early morning hours is increased vasomotor tone secondary to diurnal variations in catecholamines. The next question reads, oral amlodipine 10 mg every day was ordered for ASP. Would long-acting nitrates or beta-adrenergic blockers be reasonable alternatives to amlodipine for ASP? Is one calcium channel blocker preferable to another for treatment of Prinzmetal variant angina? Because of their antispasmodic effects and low incidence of side effects, calcium channel blockers are generally selected over nitrates or beta blockers for nocturnal vasospastic angina. All calcium channel blockers appear equally effective in preventing Prinzmetal variant angina. Intrinsically long-acting or sustained-release forms are preferred, however, and some patients may respond better to one agent than to another. In patients who continue to experience pain using maximal calcium channel blocker doses, combination therapy with a nitrate should be tried. Nitrates cause vasodilation by a different mechanism than calcium channel blockers and are effective in treating Prinzmetal variant angina. To avoid tolerance, the nitrate-free interval for ASP should be scheduled during the day so that the early morning hours when vasospasm occurs are covered by nitroglycerin. For example, ASP could apply a transdermal nitroglycerin patch at bedtime and remove it on awakening. Statin therapy is indicated for ASP. Blockade of the beta-2 receptors that mediate vasodilation may allow unopposed alpha-1-mediated vasoconstriction with worsening symptoms. Even a cardioselective beta blocker could worsen Prinzmetal variant angina. Therefore, a calcium channel blocker or nitrate is preferred. The next question reads, will ASP require treatment for the remainder of her life? During the first year of therapy, up to 50% of patients experience spontaneous remission by an unknown mechanism. This occurs most often in patients who have had a short duration of symptoms or who have normal or mildly diseased coronary arteries, i.e., isolated vasospasm without atherosclerosis. If ASP is pain-free and not experiencing significant arrhythmias or silent ischemic episodes of Prinzmetal angina after 1 year, amlodipine could be tapered and discontinued. It is also possible, however, that she will require treatment indefinitely. Modification of smoking and ethanol ingestion may promote remission of prinzmetal angina. The last question reads, KPG, a 50-year-old female executive, has undergone an extensive cardiovascular workup for exertional angina associated with a 3 mm ST segment depression. A recent cardiac catheterization did not reveal any atherosclerosis. The cardiologists believe KPG has cardiac syndrome X. What drug therapy might be indicated for KPG? Cardiac syndrome X is a syndrome of angina or angina-like chest pain in the setting of a normal coronary arteriogram, and ST segment depression during exercise. Several theories exist regarding the mechanism of pain production, including microvascular dysfunction producing ischemia or chest discomfort without ischemia in patients who may have an abnormal perception of pain. Half of patients with cardiac syndrome X present with chest pain induced by exercise followed by 15 to 20 minutes of chest discomfort. By symptoms alone, KPG's presentation does not significantly differ from that of a patient with exercise-induced angina secondary to atherosclerosis. Of concern is the finding of a 3 mm ST segment depression on KPG's ECG, which raises concern of severe coronary artery disease. The negative findings from her cardiac catheterization, however, rule against both coronary artery disease and coronary artery spasm as a cause of her symptoms, and help to confirm the diagnosis of cardiac syndrome X. Treatment with a nitrate, calcium channel blocker, or beta blocker all appear to offer some relief, but overall the response to therapy in these patients is poor. The choice of agent will likely depend on specific patient characteristics. Sublingual nitroglycerin is often ineffective at treating acute attacks, although it should still be prescribed. Often a combination of anti-ischemic therapy, analgesic therapy, and lifestyle modifications is necessary. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 307.